to all. So, welcome to the session on lupus. Lupus is every rheumatologist's delight. With its all fury, it's so beautiful. So, to chair this session, it's a honor to welcome Professor Amita Agarwal, head of the Department of Clinical Immunology and Rheumatology, SGPGI Lucknow, and Professor Archana Sonawla ma'am, head of the Department Medicine and Rheumatology, KEM Mumbai. So we have eminent speakers, and I invite Dr. Chengappa KG and Dr. Pankti Mehta to the stage. We'll start the session with Dr. Chengappa KG, and I invite Dr. Chengappa KG onto the dais.
Good afternoon, everyone. And after the blockbuster sessions we had just had, I think you all need to listen to some moderate presentations. And I've been given this topic, CNS lupus. Vasculitis is just a drop in the ocean. I am from Pondicherry, so I look at the ocean every day, so I think it's a nice topic for me. We'll be covering this topic around these subheadings. We'll be looking at the epidemiology of neuropsychiatric lupus from India. We'll be looking at how to attribute to neuropsychiatric lupus. Look at pathophysiology, I'll not bore you all with that, and some self-assessment, which I am sure most of you will get involved in. So, neuropsychiatric lupus has been defined by ACR in 1999 with 19 syndromes, but then it was kind of modified in 2001 to include 17 syndromes. So out of which these are the central nervous system related neuropsychiatric manifestations, and the rest are the peripheral nervous system manifestations. So if you look at the frequency versus severity, what we usually come across in our clinics, we get to see cognitive impairment. We may or may not detect it, but we get to see them quite often. But often they are not as severe when they come to our outpatient or inpatient departments. But then there is seizure and cerebrovascular disease, which is quite common in patients of lupus, and they can range from a minor TIA to severe status epilepticus and requiring ICU care. Then we have this small subgroup of myelopathy and longitudinally extensive transverse myelitis and NMO spectrum disorders, which often come to us and are quite a challenge, but if treated early, they have favorable outcomes. So we have these two studies from India. One is from St. John's and one is from our own center at JIPMER, where we found that neuropsychiatric lupus is seen in about 10% of the lupus population, and out of which cerebrovascular accidents and seizures are one of the commonest manifestations. And if you see the cerebrovascular disease across both the centers, it's around 3 to 4% incidence amongst all the neuropsychiatric manifestations. All right, this is fine. You say it is so much frequent, but is it commoner as compared to the general population? You know, it might be possible that even the general population has got this incidence in stroke and in other manifestations of neuropsychiatric lupus. So there was this meta-analysis which looked at age-specific odds ratio of cerebrovascular accidents, and what they found is in individuals less than 50 years old, the odds of having a neuropsychiatric manifestation, mainly cerebrovascular event, was much higher than as compared to the healthy population. It was similar amongst males and females, and it was equal in both ischemic as well as hemorrhagic manifestations. So we can ascertain that strokes, CVA and other neuropsychiatric manifestations are specific for SLE, and they are commoner amongst younger patients with SLE. But the challenge is attribution. Not all CVAs, not all strokes, not all cognitive impairment is because of lupus per se. There are so many things that keep happening with the patient. There are so many drugs, there are so many comorbidities that are to be excluded before we even can attribute something to neuropsychiatric lupus. So for that, we will be looking at the clinical presentation. Usually this is what the patient presents with, and the clinical presentation itself is so varied. It can range from cognitive impairment to headache to some sensory symptoms, or the patient could present with dysarthria or some isolated cranial nerve deficit which you are not able to figure, or it could be motor deficit with mono, hemi or quadriparesis, or patient might be in comatose or in altered sensorium. So the spectrum itself is so huge, and attribution thus becomes very difficult just based on clinical presentation. We also, besides this, there are a lot of differentials. We have encephalitis, metabolic causes, various drugs. We have malignancies. We have infective etiologies. We have demyelination and PRES, which is closely related with lupus but not seriously a neuropsychiatric manifestation. And finally, we have CVT and embolic phenomena, which happens because of extra neuropsychiatric lesions, as well as rarely vasculitis. So all this can be to some extent ascertained with all the supporting investigations that we usually do. We do a brain imaging, we do EEGs, we do CSF analysis, and we forget to revisit history, which we often have to do. There are some pointers. These are the group of patients who often have higher odds of having neuropsychiatric lupus. Clinically, males have a higher odds of having neuropsychiatric manifestations, higher extra CNS activity. If the activity overall, SLE activity overall is higher, then mostly the neuropsychiatric manifestation is because of lupus. It usually occurs within 2 years of disease onset, and any prior history of neuropsychiatric lupus actually predisposes the same patient for another episode. And autoantibodies, we know anti-ribosomal P is associated with neuropsychiatric manifestations, antiphospholipids with stroke and some movement disorder in lupus. Myotubule associated protein, which is produced by most of the neurons, has got 100% sensitivity in detecting neuropsychiatric lupus. And finally, complements usually are low in a vasculitic disorder, but if it is high and there is a stroke, it is mostly an atherosclerotic disorder. MRI features, if there are multiple territories which are not respecting the vascular territories, then it could be a vasculitic phenomena. If there is a combination of infarct and hemorrhage, besides CVT, we should start thinking of vasculitis. If the MRI or MR angiography detects changes in the lumen or wall irregularity that is detected, then it could be a pointer towards a neuropsychiatric lupus event. Finally, if the vascular wall is able to uptake contrast, is enhanced after contrast, then it would suggest an ongoing vasculitis. All this is easier said. So there was this Italian team or cohort, group that tried to do a data-driven model that could attribute to neuropsychiatric lupus. So they used a lot of weighted features. Just briefly, what they saw is if there was a contributory image, if there were specific autoantibodies like antiphospholipids and anti-ribosomal P, if the age of the patient was less than 50, if extra CNS disease activity was there, which was suggested by a very high SLEDAI, if there was biopsy evidence of vasculitis, which is rare, and after you treat, was there a response with immunosuppression, then it would favor an event of neuropsychiatric lupus. But this model, at the best, in their original cohort itself, the sensitivity was 83 with specificity of 84. So this is not good enough to treat a single patient with a rare manifestation. So ultimately, it comes down to us, we clinicians, we have to decide and we have to treat, because the patient is unwell and patient is in your ward and you have questions to answer and a patient to treat. So understanding basics of pathophysiology actually helps. Overall, what is seen is there is a breach in the meningeal barrier. Even the lymphatic circulatory system is infiltrated with inflammatory cells, and there is a breach in blood CSF barrier, especially at the choroid plexus. And finally, the blood-brain barrier itself could be disrupted. All this usually happens as a mixture of infection, or if there is a vascular insult, or there are autoantibodies which causes apoptosis of the endothelial cells. So there are some autoantibody associations as well. As we already discussed, antiphospholipids and anti-ribosomal P, they are associated with some neuropsychiatric manifestations. There is anti-NMDA receptor antibody, which is associated with cognitive affective symptoms, especially in animal models. And then there is anti-aquaporin 4 antibodies, which we all know from NMO spectrum disorder. It is highly associated with NMO spectrum disorder in lupus as well, but the pathophysiological role is not known, and anti-MAP2 antibodies is a good screening tool if it is detected in the CSF of the patient. So enough of lecturing, so let us all participate in some solving cases. So we'll first present a refractory CNS vasculitis who was a 20-year-old boy who was a class 4 lupus nephritis, who had received cyclophosphamide, was on azathioprine maintenance, and he defaults drugs, which is a common story, and comes back with an AKI with a creatinine of 4, with hypertension, with oral ulcers and fever. Absolute no doubts in this about disease activity. We are all confident. We give him methpred, we treat him with oral steroids, and also give him first dose of rituximab because he has already failed cyclophosphamide, maybe because of default, but we wouldn't want to give him more. And then there was a week later, boy develops focal seizures with secondary generalization, and we do a MRI, and it just shows a parietal infarct. Now, there is extra CNS disease activity which is quite high, and a young boy who has defaulted drugs, and this has to be a case of CNS vasculitis. We just continue him, we discharge him on the same drugs, we ask him to follow for the second dose of rituximab, but in the 15-20 days that follows, he comes back with speech loss, with rapidly progressing cognitive decline, and extra CNS lupus which had resolved completely. All the palatal ulcers were gone, creatinine was beginning to normalize. And we did a repeat MRI which showed progression of infarct with hemorrhagic transformation. Now, I already mentioned an MRI evidence of infarct with hemorrhage is suggestive of vasculitis. But then now we were really unsure, and most of you are sure it is not vasculitis. That is why it's being presented here. So we went ahead and gave him contrast despite he had a higher serum creatinine. And what we found was a ring enhancing lesion. And even the CSF what we did was not contributory in this patient. And we went on, did a biopsy of the patient, and biopsy grew chromoblastomycosis. And we treated him with antifungals, voriconazole, for 3 months. And now he's doing okay, but he has almost lost the entire hemisphere of his brain. So if there is a refractory or progressive lupus while on high dose immunosuppression, then it is often not a refractory SLE. It is usually an infection which we are not able to pick up, especially in countries like ours, where the burden of infection is so high. So a high index of suspicion as clinicians is most important. Next comes another common scenario with lupus, where a 18-year-old female with history of malar rash and ACLE for 5 months was admitted elsewhere, was being treated, and there she developed acute onset aggressive behavior and irrelevant talking after 4 days of admission. Now the patient comes against medical advice from that hospital to us, and we re-evaluate her. We find the ANA was 4+ core speckle with SMD1 positive and very low complements. So we are sure that we are dealing with lupus with some mucocutaneous lesion, but we are not sure why the patient has got this sudden onset aggressive behavior. And as we asked them, they did not take any multiple tablets, or there was no IV infusion that was given. And then, we tried to retrieve the old hospital documents which were not available, but we asked her parents to go back and try to get whatever possible. In the meantime, we were very aggressive. We went on, did a CSF, we did a neuroimaging, which was all normal, and we were beginning to, lose the plot. So we started her on antipsychotics with psychiatry being involved in it, and we started her on prednisolone 0.5 milligram. This is where we are really unsure if it is disease activity or if it is something else we are missing. And then patient's father turns up with a treatment chart from a previous hospital, and we got to know that she was given Dexapulse, and we were like, oh no. So what we did next is we tapered all steroids instead of escalating, and we discharged after 1 week of observation where she never worsened. And we waited for 4 weeks. We asked them to come back, and when she came back on week 4, she was completely a different person. So steroid psychosis is another great mimic which is often given, which is very common in lupus as compared to other diseases, and it is usually seen in doses above 30 milligram per day, and it can occur anytime from day 2 to week 2 after administration of high dose steroid. Acute manifestation is often psychosis and anxiety, but chronic can be depressive features, both parts of neuropsychiatric lupus manifestations, and it is commoner in SLE for unknown reasons, and it may take up to 3 months for symptoms to normalize even after you have reduced the drugs. So if there is no life-threatening condition and you are suspecting steroid psychosis, it would be rather wise to bring down the steroid dose rather than escalate immunosuppression in such patients. Now there is another simple case of vasculitis that I would want to discuss, because these were quite complex, one infection and one without history. Now a simple case of vasculitis with a 21-year-old female who is a known case of lupus nephritis on cyclophosphamide treatment. COVID hit and she lost to follow for 3 months. She could not get any drugs. She comes back to us with 2 episodes of GTCS, fever and pedal edema. Now fever, pedal edema, GTCS, no brainer, it should be an infection, right? So we then measured her BP. BP was okay, 112/94. Urine PCR was 4. She had low complements and slightly higher CRP. Yes, higher CRP, again infection. We were all excited. So we did a fundus which was normal. CSF was normal. And now our infection hypothesis started falling. But we persisted, and she threw one more episode of seizure while in hospital. We then went on to do an imaging with CT plus CT venogram, which is easily available. It was normal. When we thought we should do an MRI in this patient, and we found these homogeneous opacities in the posterior part of the cerebral cortex. It was a convenient diagnosis of press for the radiologist, but for us it was a week's nightmare. So cyclophosphamide was reinitiated in this patient. Her headache resolved in 2 months and no more seizures after this, and she did not have to be continued on anti-epileptic measures. So posterior reversible encephalopathy syndrome is more frequent in lupus and can occur even when the BP is normal, and this is something we should all remember. Often it is associated with presence of lupus nephritis, and some drugs, even some drugs like cyclosporine, mycophenolate can precipitate the event. Usually there are no focal neurological deficits that are associated with these MRI lesions and seizure disorders. So this is the final case, I promise, and before you all get bored. So it was a 27-year-old male who came to us, known case of SLE, predominant mucocutaneous and musculoskeletal features for the last 2 years, comes to us with dysarthria and clumsiness of hand. And he gives a past history which was very similar, and we did a brain MRI. We were expecting an embolic shower or a demyelinating lesion. So we did an MRI which showed a few white matter hyperintensities, but some had diffusion weighted restriction. We did an ANA which was 4+ homogeneous, but he was triple positive for APLA. Then we were really behind the embolic phenomena. We did a transthoracic echo. It was normal. So now we have some white matter hyperintensities, some symptoms which are not corroborating with these imaging findings, and the triple positive APLA. So we thought it could be an APLA associated demyelination, which is quite well described across literature. But in fact, on the MRI, while we discussed with the radiologist, they were convinced that there are infarcts, and infarcts with demyelination did not really favor just some white matter hyperintensities. So we did a repeat clinical examination, and we found there was a regurgitant murmur. That is how good our clinical examination is at the first point. Especially when patient has a CNS disease, we don't actually examine the heart so well. So there was some regurgitant murmur, which was also missed in the echo, and then we went ahead with a transesophageal echo, which showed a Liebman-Sachs endocarditis. So we tapered steroids rapidly, started warfarin, repeated his TE after 6 months, and everything had vanished. And he actually got married 6 months back, and he had come to us with his wife. So demyelination of white matter hyperintensities will not usually show infarcts, even if it is APLA associated. So if these are there, we should be really careful. And transthoracic esophageography has got very low sensitivity in detecting Liebman-Sachs endocarditis. Finally, we have seen all these problems. We have seen an algorithm that is designed by the Italian group, which had 83% sensitivity. But how do we still improve attribution accuracy? So only way to improve attribution accuracy is by a multidisciplinary approach. We need to pull in radiologists. We need to go discuss with them. we need to do, we go to and talk to the neurologist, we need to go and talk to the psychiatrist, also maybe the cardiologist, and finally we have to reassess all the patients. So this is exactly what this paper did. They reassessed all the 463 events that was done by the Italian cohort again and gave it to some other people, and what they saw was the agreement with the reanalysis was very poor, and 14.5% of neuropsychiatric events that were attributed as because of SLE before had to be reclassified eventually as non-neuropsychiatric lupus manifestations. So this shows us that revisiting history, reanalysis, and multidisciplinary approach is the only way out to actually, attribute these events properly to these patients. So final proof, why would you want to listen to me? These are all my experiences and our cases. So why would you want to really listen to me? Actual proof is if somebody can show me biopsies, right? Biopsies, you're telling lupus vasculitis is rare. Do you have proof with biopsies? So there was this study which was published long back in 2017. And what they found is there was a lot of microthrombi, microbleeds, microinfarction, and vasculitis in lupus nephritis, in neuropsychiatric lupus. But when we have this data from India, from PGI, which saw the autopsy specimens on all lupus patients, and out of 12 autopsy specimens they saw, 4 had invasive fungal infections and only 1 had lupus vasculitis, true vasculitis. So it is quite rare. To summarize, CNS lupus vasculitis is indeed just a drop in the ocean, as my topic was. And we have to do everything possible to disprove CNS vasculitis until we fail. And our decision matters for the gray and white matter of the patient. Thank you.
Thank you, Dr. Chengappa, for a wonderful exposition of 4 cases where you learned that you can have multiple different etiologies for neurological manifestations in patients with lupus. And our onus is always to find out, is there a non-lupus related cause for this neuropsychiatric manifestation? That should be the dictum when you manage patients with neuropsychiatric manifestation. So if we have any burning question, 1 or 2. So it looks you have done a great job, Chengappa. You can come and join us here.
I've done a very bad job.
Come. You can join us here. Maybe they will think of more questions. So now we have Dr. Pankti. She is going to talk of another dilemma in lupus. That is, when a patient with lupus comes to you with fever, how do you differentiate that it is because of infection or because of lupus flare? So Pankti is assistant professor at KG Medical College, Lucknow.
Very good evening to all of you. And so that I could touch upon the most relevant aspects of this topic in the time allotted to me, I'd conducted this survey online that what are the problems faced by rheumatologists when it comes to this topic. And no matter the experience, we've all faced this dilemma of differentiating flare and infection in lupus. And I got about 90 responses, and most observed that the frequency of infections was pretty high in lupus. Again, it is very difficult to differentiate it from flare because of the symptom overlap, drug modification of symptoms, either because they've received antibiotics or immunosuppression, lack of good biomarkers. Again, most people were not comfortable with using SLEDAI-2K to identify flare in this situation, because of overlapping features like active sediments in the urine can be there in infection as well as flare. Complements and dsDNA can be normalized because of the immunosuppression. And lastly, and the most important thing, financial constraints. Ordering multiple tests at multiple time points can get very difficult. So what are the conventional biomarkers that people are using, of which the most popular ones were complements and anti-dsDNA, procalcitonin, CRP, and neutrophil to lymphocyte ratio. Now let's see what evidence we have for these simple old markers. So neutrophil to lymphocyte ratio, we expect neutrophilia to be present in infection, and a cutoff of more than 5.7 yielded a good sensitivity and specificity to identify infection. Again, CRP is a fairly specific marker for bacterial infection, and a cutoff of 6 milligram per deciliter had a moderate sensitivity but a good specificity. ASR to CRP ratio in the original paper had excellent sensitivity and specificity for identifying flare and infection. Procalcitonin is, I think, one of the most used, or I would say abused, markers for bacterial infection. And there is heterogeneous data when it comes to this area. But a recent meta-analysis gave a good sensitivity and specificity. But a word of caution, it is a good marker to rule in infection rather than ruling it out. Now we have some Indian data here, and this was a multicentric prospective study conducted across 4 centers in India, in which we assessed 168 febrile episodes of lupus. And we found that all of these conventional markers nearly perform in a similar way, and they all have a good specificity. So CRP, which would cost about 1/10 of procalcitonin, is not a bad marker to actually identify bacterial infection. Even neutrophil to lymphocyte ratio, it's as simple as it can get. Now, what other markers that people feel are going to come up in a big way? And the most popular one was neutrophil CD64, followed by neutrophil XYZ, and interferon signature. Now let's see what evidence we have for these. Now CD64 is nothing but an Fc gamma receptor, which is normally not expressed on neutrophils, but its expression increases rapidly when faced with an infection. In the original study done in about 20 patients of lupus from Egypt, they found that the mean fluorescence intensity of CD64 on neutrophils assessed by flow cytometry was much higher in infection than in flare, and a cutoff of 43.5 yielded a great sensitivity and specificity. There's also some work done in India from this, in which about 50 patients of lupus were assessed. They studied the percentage of neutrophils expressing CD64, and they found a cutoff of 22% to give a good sensitivity and specificity. We also tried to use CD64 in our cohort. We did not get as great results as this, but we're yet to publish that. Neutrophil XYZ is again a simple marker readily given by the Sysmex cell counter. Neutrophil X is a representative of the toxic granulation, and neutrophil Y of the nucleic acid and protein content. And neutrophil Z is the vector sum of the two. So it basically gives an objective measure of activated neutrophils. And again, we had done this in about 50 patients from SGPGI, and we found that the levels were significantly high for infection as compared to flare for all the 3. We have a host of other markers, and people have studied delta neutrophil index, pre-sepsin, STREM1 to be increased in infection, and 2,5-oligoadenylate synthase is an interferon-inducible enzyme to be elevated in flare. But none of them have really come up in a big way in follow-up studies or in clinical practice. Now, molecular signature, again, this was a concept by Betty Diamond's group, in which they looked at the molecular signature in the peripheral blood of 27 patients with lupus. And they found 8 genes to be differentially expressed between infection and flare. Some of them were interferon-inducible genes. Some of them, like FLI1, are involved in the pathogenesis of lupus nephritis. And only one, myosin light chain kinase, was elevated in infection. And each of these genes individually gave an area under curve of about 90%. Again, when they only looked at the interferon signature, it was not sufficient to differentiate flare and infection. Now, can we be one step ahead? Can we identify patients who are prone to infections? So again, there's some work being done in this area. The hypothesis is that patients with lupus have reduced cytolytic activity and an exhausted T cell phenotype. And when they looked at the CD38 expression on CD8 T cells, they found that patients with lupus had high CD38 expressing CD8 T cells, as you can see the pink cells, as compared to healthy controls. Now CD38 acts like an NADase, and through the NAD sirtuin EZH2 axis, it actually reduces the cytotoxicity of the T cells. And when they took the subgroup of CD38 high CD8 T cells and went back and saw the records, which were available for about 35 patients, they found that 11 of the 13 with the high CD38 expression had recurrent infections in the last 6 months, and predominantly were bacterial infections. Now, as you must have realized till now, there's no single biomarker that is sensitive and specific enough to identify infection and differentiate it from flare. Most people felt that a score based on clinical markers and basic investigations is the way to go forward. And in fact, that is what we tried to do with our cohort. And we found that markers as simple as age, total leukocyte count, and C-reactive protein gave a very good differentiation between infection and flare. In the test cohort, we got an area under curve of about 0.88, and in the validation of 0.83. We also tried to devise some other models. If you follow the brown graph, this was age, TLC, CRP, and procalcitonin, and it gave an area under curve of 0.86. So we realized here that addition of procalcitonin really did not improve the area under curve significantly. The pink one is neutrophil Z and C4, which actually gave the best area under curve, but since we had only done neutrophil XYZ in 50 patients, we wanted to keep it separate. In conclusion, clinical features and conventional biomarkers, like total leukocyte count and CRP, are the most useful, at least in today's day and age. Amongst newer markers, neutrophil XYZ looks promising, maybe CD64. Molecular signatures in CD38, CD8 T cells are interesting. And we have a big lacuna when it comes to pediatric and elderly lupus and identifying non-bacterial infections in lupus. Thank you so much, and I thank the organizers for the opportunity.
Thank you, Pankti. That was an excellent talk, and I think what we need to understand here is that till we have any of those availability of the new markers like neutrophil XYZ, we have to still rely on the good old CRP and as such. I think pathologists do report toxic granules on the peripheral smear. Should that be helpful?
So that is a very subjective assessment, and it varies. There's a great deal of inter-observer variability, whereas this is like it measures the site scatter, so it's a much more objective way to assess it.
And any question from the audience?
Thank you, ma'am, for your excellent deliberation. I am Dr. Bodhibroto Banerjee from Calcutta. My question to you is that in some specific situations in lupus, like serositis, synovitis or vasculitis, the CRP can be elevated. So in these situations, how sensitive is the model which you talked about regarding the composite score of age, total count and CRP to differentiate flare from infection?
So indeed, there are studies that say that CRP rises in serositis and arthritis. We also tried to look at a specific subset of those in our cohort, but we did not find a significant difference. And again, a recent paper also stated that if you increase the cutoff of CRP from 6 to 10, that would increase the specificity in such scenarios.
Thank you.
So more questions. This is a very important issue for all of us. I mean, every day in the ward you would have patients where you wouldn't be able to figure out is it infection or flare. What Pankti has told you is that you can devise some markers, and this calculator which I think with Pankti we have devised is very good. When it is available free, you can try it out, all of you, because age, you know the age of the patient, you know the total leukocyte count, and you know the CRP. CRP is done available everywhere. So you can, if you want, we can put.
So today I want to talk about the recent progress in the targeted therapies in SLE. So about 20 years ago, we have treated patients with only glucocorticoid and immunosuppressant. But as everybody knows, the worst cause of death is still infectious diseases, not only in Asia, but also in Europe and United States. So because of the immunosuppression by the glucocorticoid and immunosuppressant. So that's why we need targeted therapy. However, we have tried to do clinical trials from 2002 using rituximab, anti-CD20 antibody. However,
every clinical trials have been failed, unfortunately. So next, our target has been changed to BAF and interferon. Especially interferon signature are strongly involved in the pathogenesis of SLE. Many people realize that interferon or interferon-related signals should be a good target. But when we as a student, SLE should be a B-cell disease or T-cell disease, namely acquired immune disease or autoimmune disease. Interferon and BAF are produced by dendritic cells or macrophages. These cells belong to the innate immunity. So our question was why innate immunity is involved in the pathogenesis of SLE. So, but in 2011, GWAS was assessed for detect the SNP of SLE. So then finally, about 30 disease susceptibility gene has been recognized. Half of them are related to B cell. However, half of them are related to dendritic cells, namely signaling from toll-like receptor to interferon production. Why? So many people have a special question about that. But now we realize that such a cytokines produced by innate immunity may activate or differentiate or induce the differentiation of B cells or activation of T cells. So such a bridging cytokine between innate immunity and acquired immunity may be important target for us. So then anti-BAF or anti-interferon receptor antibody have been developed. So in Asia, 2013, anti-BAF antibody Belimumab was launched. And also in Japan, US, and Europe, anti-interferon receptor antibody Anifrolumab was launched last year. And still ongoing. How about my slide? Today, I have to talk without my slides. It's okay. Anyway, so no slides? So at the same time, in 2014, European group have proposed a 3D target therapy for the management of SLE. So major target or treatment target of SLE should be remission of SLE. Also, prevention of disease flare is another important goal. And finally, lupus nephritis should be treated by glucocorticoid and immunosuppressant, but after getting remission, they have to be maintained for more than 3 years. But after that, glucocorticoid completely tapered or discontinued. That is the treatment target. So we are very upset. Maybe all of you are upset. Is it possible to withdraw glucocorticoid in patients with lupus nephritis? But this treatment target has made by the systematic literature review and also Delphi method by the expertise in Europe. So this should be a highly evident one. So we have to think about the treatment strategy of SLE. And still ready? Not ready? Okay. Today, I'll talk about everything with that slide, maybe. What next? So in terms of B cells, so everybody have autoreactive B cells, but these B cells are not required. So these B cells should be deleted by some signals in lymph nodes. However, excess amount of soluble buff are produced by dendritic cells. So soluble buff stops the apoptosis of autoreactive B cells and induce the class switch of B cells and induce the differentiation into plasmacyte. That's why soluble buff are involved in the B cell differentiation. So about 10 years ago, using soluble anti-buff antibodies, at least two BRIS-5, BRIS-52, and BRIS-76 trials have been done in all over the world. And finally, anti-buff belimumab was more superior to placebo for the treatment of SLE and also have a good tolerability. And then finally, belimumab was approved. The subsequently, as mentioned, anti-interferon receptor antibody, anifrolumab, was developed. So in TULIP-1 and TULIP-2 studies, all over the world, people have been involved. However, TULIP-1 study was failed. TULIP-2 study was successful. And TULIP-2 has been successful. And namely, the primary endpoint was BICLA. BICLA is a combination of BILAB and physician's global assessment and so on. So at week 52, there is a significant difference in anifrolumab with standard of care than placebo with standard of care. So finally, it was approved in US, Japan, and Europe too. So now anifrolumab is available in many countries. But belimumab and anifrolumab are antibodies. The molecular weight size is about 150 kilodalton, huge. So we have to use by intravenous or subcutaneous injections. Do you like needle? I don't like needle. It's better to use oral available drug. So as everybody knows, JAK inhibitors are developed in patients with rheumatoid arthritis. I'm also involved in the development of JAK inhibitor from the first point. Then, many interferon signals are activated by JAK-STAT pathways. For instance, interferon alpha or type 1 interferon induce antiviral activity through JAK1/2 and STAT1 and STAT2. But interferon alpha also induce lymphocyte activation through JAK1 and JAK2 through STAT1 homodimers. So thus, JAK is involved in the interferon-related signals. Not only interferon signals, but also many cytokines are involved in JAK-STAT pathways. So finally, JAK1/2 inhibitor, baricitinib, was developed for the treatment of SLE. So I'm one of the steering committees. Oh, good.
So finally, we have your slides, Dr. Tanaka.
Yeah. So as mentioned, antibodies are huge. However, small molecule can be taken by oral administration. One of them are JAK3 inhibitor or JAK inhibitors. JAK3 was discovered by my friend Dr. John O'Shea, and JAK3 knockout mouse shows a skid, which was found by Dr. Yamaoka. So after that, JAK3 inhibitor tofacitinib was developed. But tofacitinib is inhibit on or theoretically inhibit common gamma chain mediated signaling. So many cytokines involved in JAK1/3, JAK1/2, JAK2/2, TYK2, or TYK2 JAK1/2. If so, if we block JAK1/2, all of these signals should be blocked. Multifocal or multi-cytokine inhibitors is a baricitinib. So we have a much expression about JAK1/2 inhibitor baricitinib. And actually, phase 2 studies, baricitinib was superior to, I'm sorry. Phase 2 study, baricitinib was superior to placebo in patients with SLE. However, phase 3 trials was failed. Again failed. There are many reasons, but please think about JAK1/3 inhibitors. JAK1/2 inhibitor blocks everything. For instance, do you know in China, IL-2 induce regulatory T cells, and IL-2 are now developed for the clinical trials in SLE. Okay.
You have to say next.
Okay. Okay. Well. Please be patient. I'm also be patient. Oh, here, finally. So, JAK1/2 inhibitor blocks all these signals, multi-cytokine inhibitors. So, as mentioned, IL-2 is involved in the induction of regulatory T cells. But if we inhibit IL-2, regulatory T cell induction may be inhibited. So actually, when we check the peripheral blood of patients who are treated by baricitinib, regulatory T cells are down. So this may not be good for SLE. So then, we think about the next step. As mentioned, baricitinib blocks all these cytokines, including IL-2. This may not be good. So next step might be TYK2 inhibitor. TYK2 is involved in IL-12 signal and GP130 signals, and IL-10 and interferon. IL-2 or other cytokines are intact. So actually, in patients who are treated with deucravacitinib, TYK2 inhibitors, regulatory T cells are kept. So now this trial is under the phase 3. So we have much expectation about deucravacitinib. In phase 2 study, PASLI studies, at week 48, we could see the significant difference in placebo and deucravacitinib 3 mg BID, which are assessed by In phase 2 studies, deucravacitinib was superior to placebo, significantly superior to placebo, which shows a SRI for beta response at week 48. Actually, ducravacitinib reduce interferon gene signature, BAF, CXCL10, MCP2, other important markers. So next, our expectation is shed light upon the ducravacitinib. So this is summary finally, 20 minutes. So as mentioned, about 20 years ago, our target was B cells because many people say that B cell T cell interaction should be very important for the pathogenesis of SLE. So actually, rituximab or other B cell targeted therapy has been developed. However, all the clinical trials of rituximab or other CD20 antibody for SLE have failed. So as mentioned, in 2011, GWAS was undertaken to check the SNP of SLE gene. So half of them are detected in B cells, as shown in the right slide. So however, other half are detected in dendritic cells, as shown in the left slide. So many people have a question why innate immunity is involved in the involvement of SLE. But everybody knows neutrophils, netosis, or apoptosis, or necrotosis of other cells may secrete DNA or RNA. This DNA or RNA binds to toll-like receptor on dendritic cells. Then toll-like receptor mediated signaling through, for instance, STING or IRF7 are activated. Finally, interferon transcription are highly induced by toll-like receptor mediated signaling. So that's why many important cytokines are produced by dendritic cells or innate immunity. But these cytokines produced by innate immunity and activate acquired immunity. This appears to be a bridging between innate immunity and acquired immunity. These cytokines may be a good target for the treatment. So, as about 40 years ago, when I became a doctor, I treated patients with RA, rheumatoid arthritis, with glucocorticoid and gold. But we could not prevent joint destruction. But now, I never use glucocorticoid in patients with rheumatoid arthritis because we have DMARD, especially targeted DMARD or biological DMARD. Same dreams can be held in SLE. Now we use glucocorticoid and immunosuppressant, but if we have an adequate anti-lupus drug or orally available or biological or other signaling molecules are available, we will be able to treat patients without glucocorticoid. This is my dream and your dream, and also dream by all of the patients. So for that sake, we need bidirectional translation between clinic and laboratory, right? Basic and clinic. So for that relationship, human relationship, and our wonderful friendship and partnership in your country and in the Asian countries or European countries, United States, are prerequisites to induce wonderful progress in the science, especially for patients with SLE. So finally, this is my colleagues. And Tokyo is center in Japan. However, Kita-Kyushu, Fukuoka is western part of Japan, but almost a similar distance from Tokyo, from China, Peking, from Taipei or Shanghai. So Fukuoka is center of East Asia. In this Fukuoka, we will have a Japan Culture of Rheumatology next year, and APRA in 2025. I want to ask you to visit Fukuoka in these two wonderful situations. Thank you very much for your attention.
Thank you, Dr. Tanaka. Please join us here. Please come and join us here. Please come. Just I'll ask you some water. Have some water.
Hot.
So if you have any questions, so Dr. Tanaka has given you an overview how the treatment therapies have changed in lupus, and what we have now is much more targeted therapies looking at B cell depletion, targeting BAF, as well as JAK-inhibitors which target multiple pathways, and how from bench to bedside your concepts are very different, but ultimately what everybody is aiming at is to improve outcomes in patients with lupus. So if you have any questions, you're most welcome. So Dr. Tanaka, can you just give us a little bit of an overview on treat to target? So are you using low disease activity, LDAS, or something to target your therapies in patients with lupus, or you're using only SLEDI?
I usually use LLDAS. So LLDAS is our primary target for the treatment. So we have to approach to LLDAS as a treat to target. But if obtain LLDAS, we may next target the remission, especially DORIS remission. But LLDAS is primary target for us. So I usually routinely use LLDAS.
Yes, Dr. John. Yes.
So one of the concerns about lupus, generally we think it as a prothrombotic disease, risk of vascular events. So when JAK inhibitors are used in lupus, we always have the fear of a thrombotic event or an increased cardiovascular risk. So how do we address that issue when you have more JAK inhibitors coming into management of lupus?
So Dr. Tanaka, I can tell you the question. What his concern is that in lupus is itself a prothrombotic state. They have higher risk of thrombosis, and we know that JAK inhibitors can also increase thrombosis risk. So are you concerned?
Yeah, that is a very important question. So we have to clarify that concern during the clinical trials and also or after post-marketing surveillance. But so far, during the clinical trials of baricitinib in phase 3, we have not experienced increase in thrombosis, including VTE and PE. But this is a small size. So we have to evaluate the huge or big size, big data in real practice. Thank you very much for your wonderful questions.
Any other questions? So can I ask you one more question?
Please.
So how many patients in your clinic are you able to achieve LDAS if you start with 100 patients, and at what time point do you think? It's about 6 months, 12 months?
Yeah, it's also a very good question. So we have recently checked our outpatient clinic. Total about 850 patients are in our department. So among them, about 25 to 30% are in LLDAS. The time to the LLDAS depends on patient. If patients have major organ failure, it is not easy to do. It takes more than 1 year or 2 years. But if patients do not have major organ damage, we can achieve LLDAS within 1 year or sometimes 6 months.
Okay, so that's excellent. Do you have any questions, Singapore?
My question was, if in lupus we have different organ manifestations and a patient usually behaves in the same way. If somebody has a musculoskeletal and mucocutaneous phenotype without lupus nephritis, it is very rare that they develop lupus nephritis later on.
So what he's saying is that in lupus, generally they breed through. Whenever they have relapse, they generally have the same manifestation which they had earlier.
I see.
So is that true in the Japanese population also, or?
It's also a very good question. But when we relapse, usually we do so relapses may be divided in two: major organ relapse or minor relapse. In the minor relapse, we may recently add anifrolumab or belimumab to patient. But major relapse, we may restart with high dose of glucocorticoid and cyclophosphamide or MMF.
Absolutely. So I would like to thank all the speakers, Dr. Tanaka, Pankti, as well as Dr. Chingappa, for highlighting many aspects of lupus which are actually bothering us every day, from CNS lupus to patients who have fever, in setting of lupus to differentiate flare versus infection, and how to treat patients to target so that we can give them better quality of life as well as reduce mortality. Thank you all.
Thank you very much.
Thank all the chairpersons and speakers. We will have the next session, and we request all to have tea in between, because we are short of time. We are just continuing the sessions. Thank you all.